Dear students, this lecture about the medicamental processing, obturation of canals, and mistakes and errors in treatment, in endodontic treatment. Medicamental processing, requirements for medicines. The medicines which we use is used in treatment of endodontic treatment. Must have bactericidal action, harmlessness on the relation to periapical tissues, lack of the sensibilization, lack of the conditions to formation, the resistant form of microorganisms, have a quick effect, have to deeply diffuse into the dental tubules, this is very important, shouldn't lose effect under the influence of organic compounds, shouldn't possess the unpleasant smell and taste, has to clear canal of organic substance and provide their evacuation, has to be steady in the chemical relation and to possess long action. The methods of processing of canals. There are a lot of methods or techniques for processing of canals. Maybe with a root needle, with paper points, with endodontic needles, with ultrasonic devices, with rinse endo and laser. With a root needle, this is the old way, old technique for rinsing of canal. This canal based on for this method we have to have the needles, root needles, and we should wrap to on the needle the cotton. After wrapping of the cotton to the root needle, we should moistening and insert to the canal. Moistening with the some antiseptic materials or like sodium hypochlorite or chlorhexidinum, hydrogen peroxide, and at all. With paper, the same. Also, we should check size, one of the sizes of paper point, and we after moistening with the antiseptic solution, we can insert these points inside of canal. This is two way is the two methods are very old and aren't currently used because large amounts of fluid are needed for irrigation. Doctors mostly use the technique with endodontic rinsing with endodontic needles. For rinsing of endodontic needles, we have to now, after firstly we have to push the needle inside of canal, then have to pull back, a little bit pull back. Why? Because we have to keep the spaces between wall of canal and needle for backflowing of the antiseptic or irrigator. If we don't keep that area, the places under pressure, the irrigator may move to the apical side and may move over the apex or to the periapical tissues. That's why we have to pay attention when we irrigate the canal. First step, we have to push the needle inside of canal. Then a little bit we have to pull the needle to backside. then we can press to the syringe and to do the rinsing. Rinsing with sodium hypochlorite. Used as an irrigant of choose globally, used as an irrigant in endodontic treatment for many years, inexpensive, readily available, highly antimicrobial, has a valuable tissue dissolving action. 0.5–5.25% concentration has been recommended in endodontics. 0.5% sodium hypochlorite kills bacteria is root canal. Sodium hypochlorite solution more than 1% will effectively dissolve organic tissue. Increasing the concentration will increase the rate of tissue dissolution and antimicrobial action. Increasing the temperature has similar effect. Active ingredient of sodium hypochlorite is free chlorine. Dissolves pulp tissue and clean both large and extremely fine canals. Is able to penetrate, dissolve and flush out organic debris from inaccessible aspects of the root canal system where files can't reach. Hydrogen peroxide. Release nascent oxygen. Bubbling oxygen rising to the access opening tend to carry loose debris. Bacterial destruction. Hydrogen peroxide is alternatively with sodium hypochlorite. Due to release of nascent oxygen, the last irrigation solution should be sodium hypochlorite. Chlorhexidine gluconate. Broad spectrum antimicrobial activity, low toxicity, used in concentration between 0.2 and 2%, biocompatible, poor tissue digesting properties. Action is best when used along with sodium hypochlorite. Preparations for antiseptic bandage. Sometimes we need antiseptic bandage, especially when treatment of periodontitis. In a first visit after drenating, after opening of the canals and the extraction from the pus or inflammation or drenating of pus, we need keep inside of canal some antiseptic bandages and close that area temporary. There are a lot of kinds of antiseptics for using as a bandage. Glove oil and his derivatives, carbolic acid derivatives, pharmacrazole, camphoroparaxylphenol, quercetin, thymol, and camphorphenol. This is pharmacrazole and the medicines or antiseptics which based on the phenol group we use in treatment of periodontitis, especially when we keep the antiseptic bandage inside of canal. It based to the penetration to the or diffuse the ions to the dentin canals. That's why this bandage very important for us when treatment of periodontitis, especially acute periodontitis in first visit. But long time we can't keep inside of canal this bandage because the bandage with antiseptic materials may lose the efficacy of the materials. That's why just 24 hours we can keep inside of canals the antiseptic bandages. Obturation materials and techniques. For obturations, preparation for temporary filling. There are a lot of temporary filling materials. First, pastes containing antibiotics and corticosteroids. One of them may be ceftriaxone forte. Pastes containing metronidazole. One of them may be crinazole. Pastes containing antiseptic of long action, maybe Tempafor, one of them. And pastes containing calcium hydroxide. This is calcium hydroxide based pastes, very important when treatment of periodontitis also. Because you know that calcium hydroxide has a pH equal 12.5. You know that microorganisms can't live in this pH, because the alkaline pH after 11 may kill the microorganisms. Just Enterococcus fecalis may live in pH 11. But pH 12.5 microorganisms can't live that inside of canals. Calcium hydroxide, we after cleaning or rinsing of canals with some antiseptic materials, calcium hydroxide paste we may insert canal and keep there for one week. After 1 week, we have to change the calcium hydroxide, old calcium hydroxide, to the new portion. We have to change. Why? Because after a week, when we firstly fill the canal with calcium hydroxide, which has the pH equal to 12.5, after a week, the pH may decrease to the neutral side, maybe 7. You know that neutral pH is 7.5, and the calcium hydroxide may lose the pH to the neutral side. That's why after a week we have to extract from their old calcium hydroxide, and after rinsing, after antiseptic rinsing, and after drying, we have to again to fill canal with calcium, a new calcium hydroxide which has the pH 12.5. And this the paste calcium hydroxide we may keep inside of canal for 15 days, or maybe 1 month also. Why calcium hydroxide lose the pH to the neutral side? Because when inflammation inside of canal, inside of canal, the pH decrease to the acid side. You know that under the 7 pH, it means that there is acidic medium. That's why under influence of acidic medium to the alkaline medium, the pH of calcium hydroxide, which after 1 week may be equal to the 7.5. There are a lot of preparations or pastes based on the calcium hydroxide, maybe hycal, maybe endocal, maybe metapex, maybe vitapex. Preparations for permanent filling of canals based on maybe plastic, zinc phosphatate cement, preparation on basic of zinc eugenol, endoptur, endometazone, endometazone N, endometazone ivory, estazone. Preparation on basic of the polymeric resin IH26, IH+, Endaros, and et al. Polymeric preparations containing calcium hydroxide, CL-Apex, Acrocell maybe. Then glass ionomer cements, especially pay attention that glass and ionomer cements, the endoglass ionomer cements, which we use for endodontic treatment, no ordinary glass ionomer cement. Preparations on basic of the resorption formaldehyde. This is the old technique for filling of canals, because after filling with resorption formaldehyde paste, the crown part of tooth may change the color to the red side. Preparation containing calcium phosphate, so the commonly used doctors, and unital hard materials as gatta percha. There are two kinds of gatta percha, alpha and beta gatta percha. Beta gatta percha we use for unital hard in the called lateral condensation, but alpha we use for hot methods of condensation or filling of canals. Preparations for removal filling. Sometimes we need remove the filling material from canal for retreatment. If filling material based on the zinc oxide and eugenol, we use for it for removing endosulfide, desacclosal, and solvadent. If the materials based on the resorption formaldehyde, we may use endosol R, resorption, and eugenol destructor. Obturation techniques. First, cold lateral condensation. This is the most commonly used method. Warm condensation, vertical and lateral. Continuous wave compaction technique. Thermoplastic gatta percha injection, carrier-based gatta percha, thermofill, bifill, simple fill, and et al. First, one of the old methods, single point obturation. In this obturation, we have to fill, before fixing of the gatta percha, we have to fill the canal with pastes or sealers with the thick layer of sealers. After filling with the sealer, we should insert inside of canal one gatta percha, and then we can sever it on the crown level. After that, we can restaurate the crown part of tooth. Next way, called lateral condensation, commonly doctors use. After expanding and rinsing, and drying of canals, we should check the master gatta percha inside of canal. After checking, we have to extract from there the master gatta percha, and we have to fill with sealer, thin layer of sealer, just wall of canals. Then after filling with the sealer, we have to insert inside of canal the master gatta percha. After inserting of gatta percha, we should insert insert inside of canal the spreader and push vertically. After pushing vertically of the spreader may push or stick the master guttapercha to the wall of canal. After that, we should extract from there the spreader and insert inside of canal the next guttapercha with sealer. And we can continue like that up to filling the crown, up to crown part of tooth. Hot lateral condensation. The sequence of heat application is as follows. Make space for heated instrument with a cold spreader inside of canal. Place heated spreader into canal and laterally condense until cool. After checking with cool spreader, we should heated the spreader in the canal and laterally condense until cool. Remove the spreader cold. Pay attention this situation, no hot, no warm. We have to remove the spreader cold. Thereby allowing for contraction and reducing the risk of removing the guttapercha with the instrument. Because if you will extract from the warm, you may extract with the instrument the guttapercha also. That's why after cooling or cold the spreader, we may extract from there. Insert accessory cone and sealer. Repeat process until the canal is filled. The continuous wave technique or vertical condensation. A primary non-standardized or greater taper guttapercha cone corresponding to the last instrument used in fitted in the canal in the usual manner. The canal wall is coated with a thin layer of root canal sealer. The primary guttapercha cone or master cone is inserted up to the working length. The coronal end of the cone is cut off with the heated instrument. A heat carrier such as root canal plugger is heated to redness and is immediately forced into the coronal third of the guttapercha. An alternative is to employ electric heat carriers like torsion heat or system B, as they permit temperature control of the heat carrier instruments. The coronal guttapercha is seared off by the plugger as it is removed from the canal. A vertical condenser or plugger of suitable size is inserted and the vertical pressure is applied to the heated guttapercha to force the plasticized material apically to the apical side. This alternative application of heat carrier and condenser is repeated until the plasticized guttapercha seals the larger accessory canals and fills the lumen of the canal in 3 dimensions up to the apical foramen. The remaining portion of the canal is plugged with warm section of additional pieces of guttapercha. This is the carrier. I will explain you. Carrier-based systems. The guttapercha coated carrier is warmed in the decided oven. Swiftly inserted into the prepared and sealer-lined canal. The carrier is then severed before final restoration. This is the thermophil, the stove for melting, for the heating of the guttapercha. The obturator for filling of canal, and the verificator for measure of the diameter and length of canal. The size of verificator have to be equal to the obturator. If last verificator, what size we used, after this verificator we have to use the same size of obturator. After heating on the stove, we have to immediately insert the canal. During the maybe 5 or 6 seconds. If you will late, you have to extract from there and repeat again after heating and insertion inside of canal. The core material, the bifill and obtural system. The core material is heated outside the mouth and injected into the canal system using the commercially available devices. A master cone is not usually used, and the canal should be coated with sealer before injection. Obtural system, guattaperce cartridges are inserted into the gun and heated to 200 degrees Celsius. It can then be injected into the canal. Conservative surgical therapy. Apicectomy and apical curettage. Apicectomy, for it we have to raise the flap. After raising of flap, we have to trepanate the alveolar bone with low speed handpieces and round bore. Low speed. Pay attention here. Low speed handpieces and bores. We have to trepanate the alveolar bone. After opening of top of root, we may use the high speed handpieces and bore for cutting of top of root. After sewing the top of root, we have to curettage that area. Around the root and inside of alveolar bone. We have to extract from there if there is filling material, if there is granulation tissue, granulating tissue, we have to extract from there. After when we use this method, inadequate sealing of the canal, when accessory canals which we can't fill, when fractures on of the root, when pathological tissue around the root apex, especially when difficult granulomas or abscess. Because if you remember, we said if the true granuloma located far from the apical area, we cannot treat this periodontitis. In this situation, we need for apicectomy or another surgical methods. After curettage, after cleaning that area, we need retrograde restoration. We have to make on the root, the or round or square like places, and we have to fill that area with retrograde restoration. For it, we may use composite material, amalgam, or some cements or as the glass ionomer cement, especially we use glass ionomer cements. Root amputation and hemisection. Root amputation is surgery performed to remove one or more roots of a multi-rooted tooth without removing the crown. Pay attention here that after rinsing of flap, we should amputate one of the root where located or the excess of filling material, maybe inflammation, maybe granulum, maybe abscess or something, which we cannot treat. That's why we have to keep the crown part of this and amputated the root part. And the crown part of tooth we may keep as a molars or posterior teeth, but these posterior teeth will be present as a single root tooth. Hemisection, a procedure in which the root and the crown are cut lengthwise and removed. Here we have to, before extraction of the root, we have to separate the tooth to two parts. After that, we may extract the root with the parts of with the crown part, partly of half with the half part of the crown. After extraction, both situation. After extraction, we may clean that area, and we have to fill that area with bone material. After hemisection, we may to make here from where we use the hemisection, from that tooth to the adjacent tooth, we may to make the bridge, or we have to wait after 6 weeks. We may insert that area the implantation. This is the amputation. This is hemisection. Again, after separating, pay attention here, the inflammation or granulum located on the one root. That's why we need keep healthy the another root, and we need to extraction of where located the granulum. After extraction, in this situation, is made here the bridge. Coronal radicular separation. Coronal radicular separation is used when the inflammation or granulum or abscess located between roots or located on the bifurcation. Mostly this technique is used on the lower molars when the inflammation located bifurcation. After separation of the crown part, we have to clean the bifurcation area and until the healthy alveolar bone. Then we, if we need, we have to fill that area with alveolar bone and close that area. And in this situation, from one multiple root tooth, we may make two single root teeth. Finally, mistakes and complications when endodontic treatment. Mistakes are painful when they happen, but years later, a collection of mistakes is what is called experience. This is the words of Dennis Waitley. Next mistakes may be access related, treating the wrong tooth, missed canals, damage to existing restoration, access cavity perforations, crown fractures, instrumentation related ledge formation, cervical canal perforations, mid-root perforations, apical perforations, separated instruments and foreign objects, canal blockage. First, when preparation of cavity, the maxillary anterior teeth. When we prepare the cavity, we have to pay attention the direction of burr. If the burr is took to the vertically to crown part of tooth, and we prepare quickly or with high speed, we make perforate the crown part of tooth, especially around the cervical area. That's why when we prepare it, firstly we have to use the round bore for making of places on the surface, on the palatal surface of anterior upper tooth. After making of the places, we have to change round bore to the fissure bore. And fissure bore we have to take parallel to the crown part of tooth and direction to the mouth of canals, to the root side. After opening of pulp chamber, we should expand the mouth of canals with or piezo reamer or gates gliding. Especially, we have to pay attention the neck area and when we expand the mouth of canals, we have to pay attention the lingula were located palatal on the palatal side. We have to slowly prepare that area, or with burrs or with gates glidance, for easily insertion of endodontic instruments to canal. When mandibular anterior teeth, we have to open the pulp chamber from lingual side near to the cutting edge. We can't open from left side, from right side, because if we will open from left or right side, we can't professionally use the endodontic instruments, and we may broke the instruments during the treatment. That's why don't forget that on the mandibular anterior teeth we should open the pulp chamber from lingual side and near to the cutting edge. When prepare the molars, we also have to pay attention for perforation of bifurcation or perforation of crown part of tooth. When we prepare, especially when we perforate the bifurcation, when the pulp chamber is calcified or the mouth of canals closed with the denticles. If we will continue preparate with round bore and with high-speed handpieces, we may easily perforate that area. That's why if the pulp chamber calcified or the mouth of canals there is denticles, we have to change our handpiece to the ultrasound devices. With ultrasound, with round special round bores for ultrasound, we have to slowly open the mouth of canals and to extract from the, if there is denticle, we have to extract denticle from mouth of canals. After that, we may continue with expanding of mouth of canals. And we have to know about topography of pulp chamber, or topography of canals, mouth of canals. We should, when we preparate on the lower teeth, we have to prepare to the distal side. When upper molars, we have to start preparation to the palatal side, because in these sides there is the more places for rotation of our bores. Then we have to pay attention the molar, how located the tooth. If located the posterior tooth located normally or parallel to the another teeth, this may be easily to open the pulp chamber. If located a little bit curved, we have to change our technique or preparation inside of pulp chamber, equal to the tooth station. Instrumentation related errors. First, ledge, then zip and transportation, perforation, strip perforation. Ledge. When the tip of an inflexible instrument with the cutting tip goes into the wall of a curved canal, causes loss of the working length. Smaller flexible instruments with non-cutting tips are pre-curved in order to regain access to the original canal. Zip and transportation. Zipping is the result of the tendency of an instrument to straighten inside a curved root canal. This results in over-enlargement of the outer side of the curvature and under preparation of the inner aspect at the apical end point. Therefore, the terms straightening, deviation, transportation, and hourglass shape are also used to describe this type of defect. Apical perforations may occur as a result of preparation with inflexible instruments with a sharp cutting tip. Strip perforation. Due to overzealous instrumentation towards the inner wall of a curved canal, common in mesial roots of lower molars and ribbon-shaped premolars. Apical blockage. Apical blockage of the root canal occurs as a result of packing of tissue or debris and result in loss of patency and working length. As a consequence, complete disinfection of the most apical part of the root canal system is not possible. Patency filling through irrigation are important to prevent blockage. Instrument separation. The two most common cases of instrument separation are instrument fatigue from overuse and applying excessive apical pressure, usually with a rotary motion. Management options: retrieval, bypass, instrumentation and obturation to the file level. Surgical options: apicectomy, root amputation, hemisection, intentional replantation and extraction. Instrument aspiration and injection. Aspiration and injection for foreign objects are potential complications that can occur during dental procedure, such as root canal therapy, implantation, extraction, and even routine examination. The foreign objects included endodontic instruments, implant components, burrs, posts, teeth, orthodontic breccias, restorations, and even a dental mirror and irrigation needle. This is the appendix removed from a patient after an endodontic file ended up in the appendix. After X-ray examination and after extraction of appendix with endodontic file. Hypochlorite accidents. A hypochlorite accident refers to any event where sodium hypochlorite is expressed beyond the apex of a tooth and the patient immediately manifests some combination of the following symptoms. First, severe pain, swelling, profuse bleeding. Early recognition of symptoms of a sodium hypochlorite accident. Immediate severe pain for 2 to 6 minutes. The speed effective local anesthesia. Immediate edema in adjacent soft tissue because of perfusion to the loose connective tissue. Extensive edema, possible extension of edema over the injured half side of the face, upper lip, and infraorbital region. Profuse bleeding from the root canal, profuse interstitial bleeding with hemorrhage of the skin and mucosa. Emphysema, cryptus of the swelling, and epithelial necrosis. Like that, this is the picture after errors with sodium hypochlorite. Treatment of a sodium hypochlorite accident. Remain calm and inform the patient about the case and the nature of the complication. Should immediately inform the patient. Immediately irrigate with normal saline. Delay the sodium hypochlorite. Let the bleeding response continues as it helps to flush the irritant out of the tissues. Use cold compressors to minimize the swelling. Use a warm, moist pack after 24 hours, 15- intervals. Advise rinsing with normal saline for 1 week to improve circulation to the affected area. Provide pain control. A unital control of acute pain can be achieved with anesthetic nerve block, analgesics, and obturation related mishaps. Over or underextend root canal fillings. Root canal filling material is sometimes inadvertently extruded beyond the apical limit of the root canal system. ending up in the periradicular bone, sinus or mandibular canal or even protruding through the cortical plate. Crossover extensions can lead to symptoms and treatment failure. A frequent case of this mishap is apical perforation with loss of apical construction, against which facultş is compacted. This is X-rays in first station. In one root, the perforation around the apical area. Another root, the filling is extracted over the apical area, and the next pictures after perforation on the bifurcation. That area, the perforation area, is filled with sealer and kattaperça, but the canal is empty. In multiple, this is the lower posterior teeth. On the there is perforation between root or bifurcation. After perforation, filled that area with kattaperça and with sealer. Here, the pin inserted to the two bifurcation side, no, to canal side, to bifurcation side, and after present the pin here on the bifurcation, there is granulating of the alveolar bone, the bifurcation area. Thank you.